Hey everybody, and welcome to another online tutorial. This one is in Module 2. It's Pulmonary Hypertension, and is presented by me, Nicholas Garcia. Alright, so again, this is pulmonary hypertension or pulmonary arterial hypertension. I'll also refer to it as PAH. I'll use the three terms interchangeably throughout this lesson. The objectives, as outlined in your syllabus, are the etiology and pathophys regarding PAH, the clinical manifestations, what do you have to look for in terms of signs and symptoms, and of course the treatment, management, and possible prevention. So what is primary pulmonary hypertension, or pulmonary arterial hypertension? Pulmonary arterial hypertension is a progressive disorder characterized by abnormally high blood pressure or hypertension in the pulmonary artery, the blood vessel that carries blood from the heart to the lungs. So again, just a little recap on some pathophys. We know that not all arteries carry oxygen. If we look at the circulatory pattern of the heart, the right chamber, the right atrium, the top right chamber, the right atrium is going to receive deoxygenated blood from the superior and inferior vena cava or cava from the rest of the body. It'll then send it down into the right ventricle into the pulmonary arteries. That's the deoxygenated blood going to the pulmonary arteries, where it's going to go into the lungs. And of course, we think of the lungs as these air sacs that are hollow and, again, these kind of hollow structures. However, it's kind of an intricate pattern that's inside the lungs. They follow these vessels that, go from large structures to further branched out structures to further branched out structures until they reach these alveoli, little air-like sacs. And around these little air-like sacs, we have the venous system, and then it will connect directly to the arterial system. And where it'll, the gas exchange will occur, and then it'll return via veins, and then back into the left atrium, the left ventricle to the aorta, to the rest of the body with oxygenated blood. Now that's ideally how everything's supposed to work. Well, in the case of pulmonary arterial hypertension, we get some occlusions in the pulmonary arteries, or the pulmonary vascular system in general. And it's not just, it's interesting to note that it's not just, it doesn't just affect the arteries, but rather the vessels in the lungs in general. But, originally it starts with that, those arteries going into the lungs. And once we get some inflammation and some changes in the endothelial layer of those cells, that we start to get occlusions, and it starts to raise pressure, and then we get some hypertension in that area. So again, pulmonary hypertension occurs when most of the very small arteries throughout the lungs narrow in diameter, which increases the resistance to blood flow through to the lungs. To overcome the increased resistance, blood pressure increases in the pulmonary artery and in the right ventricle of the heart. The increased blood pressure can damage the right ventricle of the heart, leading to, basically a right-sided heart failure. Primary PAH, or pulmonary arterial hypertension, occurs in the absence of other lung disorders. So a lot of times it's of idiopathic origin. There are some links to certain drugs and genetic marker mutations that seem to be, raise the probability of getting this condition. In this condition, typically when it presents symptomatically, it's already in its latent phase, which, this is potentially a very serious condition. Often PH isn't diagnosed until late in the disease process, when the heart and lung have already sustained significant damage. So how does it happen, and what causes PAH? So again, as we said, it's how it happens is the blood vessels constrict, the ones leading into the lungs, and eventually ending in that intricate pattern into the alveolar structures. And then with those constriction in those vascular structures. Pressure rises in the pulmonary arteries and decreases blood flow throughout the lungs. This leads to poor perfusion and gas exchange, resulting in hypoxemia, because eventually the blood will still try to flow to the rest of the body. However, it'll be not as oxygenated. Okay. The continuous workload of the heart causes right-sided heart failure or cor pulmonale or cor pulmonale. Death usually occurs 2 years after diagnosis. Again, this usually results because by the time it is diagnosed and detectable, damage has already been set in the lungs and heart. So what causes it? It occurs in the absence of other lung disorders, as I mentioned previously, and the cause is unknown to any large degree. About 50% of patients with PAH have mutations in the BMPR2 gene that codes for growth factor receptor. There's also some other genes that we'll mention later, and they're not super important to remember. Just, there's some genetic abnormalities that can contribute to this disease process. So there are classifications to pulmonary arterial hypertension. As we can see, there's a 1 through 4 category. The first one is pulmonary hypertension, diagnosed through pulmonary function test and right-sided cardiac cath. So basically, it has to be diagnosed, but once it's diagnosed and the patient has no limitations of physical activity with moderate physical activity, with no limitations of physical activity, with moderate physical activity does not induce dyspnea, fatigue, chest pain, or lightheadedness. Basically asymptomatic. However, we've had the diagnostic studies to confirm the disease process has started. That's basically level 1 or classification 1. Classification 2 means you've been diagnosed and there's no manifestations physically at rest, but mild to moderate exercise or activity will induce dyspnea, fatigue, chest pain, and or lightheadedness. The third classification, there's no or slight manifestations at rest, but minimal activity will induce dyspnea, fatigue, chest pain, or lightheadedness. And then, of course, the worst category, dyspnea and fatigue, will present at rest, and you're unable to carry out any level of physical activity without inducing those symptoms. This will also produce manifestations of right-sided heart failure. For obvious reasons, as we discussed the etiology and pathophysiology, it greatly affects the right side of the heart, which will cause that back up into the systemic, the distal extremities and such. So we're going to see the dependent edema, the distended jugular vein distension, and enlarged liver. So who gets it? Rare, but it occurs mostly in females between 20 and 40 years of age, and those with the genetic predisposition. Again, we already mentioned BMPR2, but there's also PPH1, SMAD9 gene mutations, okay? So the signs and symptoms, what do we have to look out for as a nurse? We have to be keen. We have to be constantly looking for signs and symptoms. And again, as I've mentioned before in other lectures, we have to just basically say, okay, this is here, that shouldn't be there. So what are those signs that we should be looking for? The most common and early signs are dyspnea, fatigue, and possibly with some fainting spells or syncope, or near syncope. Chest pain, of course, and lightheadedness. So how do we diagnose it? Diagnosis is basically right-sided heart catheterization showing increased elevated pulmonary pressures. So we know that normal blood pressure in general is going to be between 100 to 140 millimeters of mercury. And diastolic, of course, being 60 to 90 millimeters of mercury. However, this is coming from the left ventricle, the strongest part of the heart. When we're talking about the right side of the heart, it shouldn't be as strong, or doesn't need to be as strong, rather, because it's not going into the systemic system, but rather up into the right ventricle, out into the pulmonary arteries, and then back into the left ventricle, or left atrium, rather. So because of this, people with PAH typically have higher than 25 millimeters of mercury of pressure at rest, or 30 millimeters of mercury during physical activity. The pressure in normal pulmonary arteries is 80 to 20. So it's interesting to note, when we're talking about 100 to 140 millimeters of mercury for, normal blood pressure, well, pulmonary blood pressure should be more like 80 to 120. We could also do ventilation perfusion scans, pulmonary function tests, and CT angiopulmonary tests. So how do we treat it? Well, think about it. Top of the food chain is always going to be airway. So, when we're thinking about NANDAs and we're thinking about how to label this, we're probably thinking already impaired gas exchange, right? Because of those structures being constricted, compromised circulation going into the lungs because of those inflamed or those changing arterial structures. So because of it, we're going to need to treat symptomatically. First of all, let's put O's on them. Let's put some oxygen on them, right? Drug therapy that reduces pulmonary pressures by dilating pulmonary vessels and preventing clot formation. So right away we start thinking about calcium channel blockers for dilation, warfarin to prevent clot formation, endothelin receptor antagonists. Now these are ones that we're not very familiar with, and I'm sure you didn't go over in pharmacology, but these are something to be aware of. For these, we want to know about bosantin. It's trade name Tracleer. It causes blood vessel relaxation, decreasing pulmonary artery pressure. However, with these, just like maybe diuretics, or rather, something like a vasopressor, they're going to have a systemic kind of vasodilation. So it's not just in those pulmonary arteries, but rather in all the vascularization. So we have to watch out for hypotension, low blood pressure, or hypotension. The other pharmacological category to treat this, and more specific category, is prostacyclin agents. And these are the best specific pulmonary arterial dilation. Now there are certain medications, as we come to learn, that work on specific regions, and this prostacyclin agent is specifically for pulmonary artery dilation. Digoxin, okay, and diuretics. So digoxin is going to strengthen the heart contraction, and diuretics is going to get rid of that excess fluid, right? So basically that's it in terms of pulmonary hypertension. This could lead to this is potentially a life-threatening disease process, so I want you to review this thoroughly. AGI doesn't offer too much on it, so as you can see, I had to reference some other resources. The National Library of Medicine has some pretty good resources, and also there's a couple of videos on YouTube. One of them is, let me see if I can't get you a good source real quick. So this one here is a good little, it's through the National Heart Center, and it's of course from Singapore. However, it has a good little animations on showing you the restructuring of the endothelial layers of the arteries leading to the lungs. So you might want to take a look at this. And that concludes my lecture. Thank you so much.